Yes, sir. We can start, sir.
Is it visible now?
Yes, sir.
Okay. So this slide we just finished. Now, how to treat severe hyponatremia when sodium is less than 125 milliequivalents? All of you would have by this time seen cases of hyponatremia in your experience with patients post-op or ICU or long-term critical illness patients. So how do you treat them? If the sodium is 125, straight away give 3% saline or
We'll check if he's symptomatic, sir. Take RNA symptomatic.
so if the sodium is less than 125, this is the flow chart. So see for the symptoms whether there are any seizures, mental status changes. Then infuse 3% saline at the rate of 1 to 2 ml per kg per hour with the goal of increasing serum sodium by 6 to 8 milliequivalents per liter, but not to exceed 10 to 25. So all of you know that rapidly giving 3% saline will cause osmotic myelinolysis. So it should not be given rapidly. So slow correction should be done. And this is the guideline 1 to 2 ml per kg per hour. That means for a 70 kg man, you can give anywhere from 70 to 140 ml per hour of 3% saline. And check the osmolality and so serum sodium level every 12 hours to find out whether the correction has been made adequately or not. If it is not responding to this 3% level, then we can consider using desmopressin 1 to 2 microgram for every 4 to 6 hours. That is the second alternate. Or give a single intravenous bolus dose of 100 to 150 ml of 3% saline with the goal of increasing the serum sodium level by 2 to 3 milliequivalents per liter. Then check sodium every 20 minutes until symptoms resolve. This is for very acute cases where there is a seizure or severe disorientation and all these things. And repeat the bolus twice if symptoms do not resolve. And if the symptoms get resolved, then you can check serum sodium level every 2 hours, adjust infusion rate and switch to isotonic saline. And or if it is not getting resolved, you can determine the underlying cause and try to correct that. And how to treat the value between 125 and 135. If the patient is asymptomatic, water restriction, controlled use of Vaptan, systemic water restriction only, initially along with Vaptan. Now, Soundarya's main confusion is with SIADH, correct, Soundarya?
Yes, sir.
So here the main problem is body releases too much of ADH. So if there is too much of ADH, what should happen? Will the patient have low urine output or high urine output? Antidiuretic hormone is produced in excess quantity. So should it result in low urine output or normal urine output or high urine output? Huh?
Low urine.
Normal action of antidiuretic hormone is to reduce the diuresis, to retain water. Whenever patient is in hypovolemia, the plasma osmolality, that is what I told you in the earlier slide. The action of ADH comes in only when there is patient is hypovolemic. Plasma osmolality increases because of the water deficit and sodium becoming higher there. and that will stimulate or give the signal to thalamus. Thalamus will cause the pituitary to secrete anti-diuretic hormone so that urine output will be reduced, water will be conserved, aquaporins will be inserted, more water will be reabsorbed from the plasma filtrate, and volume restoration will happen. That is the normal action. Now in SIADH, it has become inappropriate. Okay, syndrome of inappropriate ADH. That is the expansion of the word SIADH. So here there is an increased production or release of ADH, but this does not. This is not needed to reduce keep the water back. Okay, patient is not actually hypovolemic, but the brain, the posterior pituitary releases too much of ADH. So the excess water dilutes the sodium in blood, causing low sodium levels. So even in a non-hypovolemic patient, ADH is unnecessarily produced by the pituitary, which causes its normal action of retaining the water. So normal urine output goes down. So the excess water that is accumulated dilutes the sodium in the blood, causing low sodium levels. This is the pathology. Is it clear, Soundarya, for you?
Yes, sir. Yes, sir. Yes, sir.
Okay, right. So the kidneys are unable to effectively remove excess water, leading to concentrated urine. Okay? Because the water is being reabsorbed by the action of ADH, even in the absence of hypovolemia, the urine output comes down by the normal action of ADH. So symptoms can range from mild, such as nausea and headache, to severe, including confusion, seizure, and coma because of the excess water load. Now, the causes for ADH may be antidepressants, pain relievers, diuretics can cause this. Also, pneumonia. There are several etiologies. So, pneumonia, emphysema, and other respiratory illnesses also can lead to SADH. Just like your ARDS being caused by pulmonary and extrapulmonary, SIADH is several causes. And by most common is head injuries or neurosurgical patients, especially meningeal tumors which are operated, they are likely to go in for this syndrome of inappropriate ADH infection. So the classical features of SIADH are patient is normovolemic or hypervolemic. They are never hypovolemic or dehydrated, but in spite of that, excess ADH is produced, and the ADH causes its normal action of water retention. So urine output decreases or becomes concentrated. And because the water is retained more than what is required, sodium levels come down. So patient goes into hyponatremia. This is the very simple mechanism how the ADH is caused. And this can also happen in lung cancer, which produce excess ADH, leading to SADH. So the treatment for that is fluid restriction, and you can use the Vaptans. This is one condition where the vasopressin receptor antagonists are, which are going to block the action of the ADH. They are indicated here so that you will have a normal urine output and you can cause the normal volume to be excreted. So by restricting the intake as well as increasing the urine output, you can treat this condition. So the treatment for this is fluid restriction and use of Vaptans in the to antagonize the action of ADH. And you can also use another called demiclocycline, which is an anti which also blocks that urea and addressing the underlying cause, the etiology. So if the patient is on antidepressant, you stop that, or if they are on diuretic, stop that. If they are on pneumonia, emphysema, try to treat that. Head injuries, reduce the intracranial tension or other causes of that leading to SADH. So like that, you can treat the cause. So these are the treatments for SADH. Is it okay, Saudharya? It's clear now?
Yes, sir. Now understood. Yes, sir.
Right. So what is hypernatremia? So normally we come across more cases of hyponatremia in our practice, but we rarely can come across hypernatremia also. How is it caused? The condition where blood sodium levels are abnormally high, typically above 145 milliequivalents, and it may be because of excessive water loss from sweating, vomiting, diarrhea, or kidney issues, and or not drinking enough fluids, particularly infants and elderly individuals. They can go into hypernatremia. And excessive sodium intake, either by salt ingestion or some medical treatment, that also can lead to that. And diabetes insipidus is one condition where there is excessive diuresis happening, concentrating the plasma volume. That also can lead to hypernatremia. So how to treat that? Here we have to again assess whether the patient is hypovolemic, normovolemic, or hypervolemic. Okay, so it can also be chronic hypernatremia, hypernatremia due to hyperglycemic correction, or acute hypernatremia. So main here is to replace the water deficit. So once you restore the volume, patient will automatically dilute the sodium in that and it will become all right. So the main treatment is 5% dextrose, because once you give dextrose, not in patients with hyperglycemia, but in patients with pure hypernatremia with a normal blood glucose, the treatment of choice is 5% dextrose. So once you give 5% dextrose, what will happen? The dextrose will be metabolized by using the insulin, and it will become pure water, and the water will dilute the plasma and bring down the sodium level. Okay, that is the mechanism how it will act. And patients who are hyperglycemic, we go for 0.45% normal saline, which may contain some amount of sodium. You may be thinking that how can saline be given for a patient who is in already hypernatremia? But here what happens? The hyperglycemia is also there, so you cannot give 5% dextrose. So you give half normal saline. This will draw water from the interstitial fluid and correct the plasma volume to reduce the sodium level. So that is the mechanism by which this will act. And again, in acute hypernatremia, you can give 5% IV dextrose at a rate of 6 ml per kg per hour. Whereas in chronic, you give 1.35 ml per kg per hour up to 150 ml per hour as the correction of the hypernatremia. Okay.
Yes, sir.
So this is all about sodium imbalance and how to correct that. Okay. Any doubts on that? Any questions?
Clear, sir, no.
Okay. If you have don't have any questions right away, you can just keep a note and then clarify it next class also.
Yes, sir.
So shall I go on
Yes,
to
sir.
the next topic? Shall we go to
Yes,
the
sir.